This is Impact Healthcare.
Attention. This podcast has been disrupted.
Welcome back to another episode of the Dysrupt Healthcare Podcast. And this is a subject and a category that I mean, this is nerd among nerd talk, and I just love it. And we've got a guest, Doug Hetherington. Doug, for those folks that have never heard you, your company, give us an introduction.
Yeah, Doug Hetherington, reformed broker. At some point in time, lost favor with the insurance carriers and decided I actually would start talking to providers. And next thing you know, I find myself doing direct contracting between employers and health plans. So about 8 years ago, founded Health to Business based out here in Idaho. And we're really what we call ourselves a direct contract administrator.
So, Doug, I'm going to start in the nerd part of the conversation first, and you maybe hinted to this, right? You became disillusioned with the current. Find people that have that common thread. There was a why. There was a story. Yeah. There was like something that happened. Can you share that with the audience?
Yeah, probably a few. So second day on the job, second generation into the business. My mom was a legend, as they used to say out here in Idaho when I started. This was back in 2002, and I'm in her office, and I see the Blue Shield of Idaho moniker, and Broker of the Year down below it with these years, and then right next to it is Blue Cross of Idaho with alternating years, Broker of the Year. And I'm looking at this and I'm going, what? I don't get it. And I looked at my mom and I'm thinking, Mom, this is awesome. You are winning Broker of the Year every single year. And she goes, well, it's really not that difficult. She goes, the reality is where we live, I've got the biggest groups. I just move them back and forth every year. And so I win Broker of the Year every other year with each of them. And I'm just sitting there and I'm like, wait a minute, what? And she goes, yeah, we only have two choices, blue and blue. So that was really my introduction to the industry. Not long after that, we added a few other carriers, but I just kept noticing that every time it was like, I'm delivering a 15%, a 30%, and you go to the carrier and you're like, why? They would point the finger everywhere else. And I'm thinking, well, why aren't you guys ever pointing the finger back at yourselves? You're the only ones that are offering any plans here, right? So, I think that was the first part. At one point, I fell in love with self-funding. It just seemed to me you got more control, more transparency, all those buzzwords we hear. And at one point, I found myself in 2009 in a conference up in Sun Valley, Idaho. And the keynote speaker happened to be Governor Michael Leavitt, who at the time had just come out as the HHS secretary under Bush. And his presentation was explaining to us how the House and the Senate were each advancing health reform now under Obama. And it was through a scenario that he threw out there of, here's what's wrong with healthcare. And, we all, we all are going to get sick at some point. Well, let's just assume it's you. You're not feeling great. You go to the doctor and the doctor tells you you have advanced cancer. You have 6 months to live. However, if we treat it very aggressively and spend, I think at the time he said 300,000, right? This is in 2009, fast forward today, let's call it $1 million. And he says, if you spend $1 million, you can buy yourself 2 more years of life. Would you pay? Right? And he's kind of saying, take insurance, set it to the side. And you're kind of going, oh, there's probably 300 people in the room, right? A bunch of executives from healthcare, sales guys like us, and employers. And I'll bet you maybe 3 or 4 hands went up was it, right? It's the pragmatic side of us all going, that's a lot of money. I can't do that to my family.
Right?
Pauses for a moment, and then he says, okay, now change it up a little bit. What if that's your mother? What if that's your spouse? What if that's your child? And I mean, you just start looking around the room, and every single hand went up. And right there, that's when he said, that is what's wrong with healthcare. So the next one was when I discovered reference-based pricing. Had this great idea of starting a captive around it, partnered up with a Fortune 500 carrier, kind of issuing their captives. Each employer was going to have to do RBP. And I started running across Idaho doing events and educating employers around this. And it was really interesting that we're in the eastern part of the state. We're about 2 weeks out from one of the events I have scheduled, and I get an RSVP from the CFO of one of the local hospitals, right? And this is like a 700-man group. In Idaho, there's not a whole lot of 700-man groups. So I'm looking at it going, I'm excited, right? So I send an email out to the rep for the carrier, to the TPA that was involved, and of course the rep for the reference-based pricing organization. And to a T, all three of them immediately write me back and say, you got to uninvite him. Do not let him in the room. He's going to run your event, right? And I'm sitting there, to your point, right? We watch the behaviors of what goes on in our industry. And I sat there and I thought about it and I go, they're right. I know they're right. I don't care. They don't live here. They don't have to deal with this guy and suffer the consequences of going in and now dictating to a healthcare center what we're going to pay for services. So I told him I'm letting the guy in the room. Day of event shows up. I'm up front getting everything ready. We're about 15 minutes before we're starting. And all of a sudden, this older gentleman, gray hair, three-piece suit walks in the room. And right in Idaho, nobody wears a three-piece suit. So I knew exactly who it was right when I saw him. And I'm sitting up there and I'm kind of pretending like I don't really see him. He goes up to the registration desk. He seems like he's smiling, pretty friendly. And next thing you know, right, our gal that's kind of taking everybody in at registration, she points over to me. He makes a beeline, comes over, walks up to me, extends his hand and says, I'm Jeff Daniels, the CFO of Bingham Memorial Hospital. I'm here to see what you're about to do to me.
Wow.
I was like, oh, man, how do you respond to that? And I thought for a moment and I realized I didn't know how to answer that question. Like, I knew what it did for the health plans, right? But I didn't really understand exactly how it impacted the provider. So I told him, participate, Jeff, because I want to better understand your perspectives. Here's the thing. If we present anything that's illegal, unethical, just downright dirty, raise your hand and say something, because I don't want to do anything to you. I'd rather do something with you. Handled it well. I find myself at his office 2 weeks later, sitting across from him after the TPA and the repricer are now telling me, go get a direct contract. And I'm sitting here and I'm thinking, that sounds like a great idea. How do I do that? What's really a direct contract? Oh, well, just go negotiate a reimbursement schedule. And I'm thinking, I'm a broker. I sell products, man. I have no idea how to negotiate a healthcare agreement. I don't even know what this would look like, right? So I'm just so green at this. So I did what any good salesperson does. I walked into his office. I sat across from him. And as opposed to trying to negotiate to him, I put him through the pain funnel. I said, Jeff, can you explain to me what it's like to be the CFO of a community hospital? That was one of the greatest educations I ever received and probably the most pivotal meeting I've ever had in my career. Because by the time I walked out an hour later, I had figured out a few things. One, hospitals are bad businesses and the people leading them are bad business people, not because they're not smart or don't have a desire. It's their structure, right? They have to be prepared for anything and everything. And in most cases, especially in his, they're governed by a municipal entity, the local county. So he's operating just like a tax entity would. And you're going, oh my gosh, okay. So that was the first part. Then we started getting into a little bit of his relationship with the commercial payers. Oh my goodness. My mind was completely shifted, because all the while I'm thinking everyone's getting rich in this game except for me and my clients. So it must be him and the insurance carrier that's making all the money. Man, when he started using terms like they have the gun to my head, next thing you know, he's discussing what it's like to be in a meeting with them when they're negotiating, right? And he says, I'm always the last one to walk in the room because I want to be close to the door, because when we leave and I shake their hands and smile, I'm backing out. I will never turn my back to them because they will stab you the moment that you do. I'm like, this is literally how you're engaging with the carriers? Then the next part was he tried to negotiate with me. And what I learned in this was that everything's a negotiation in healthcare. And it's this assumption that you've already gotten a bad deal as it is. You don't really want to be in the room with that person. So you're literally trying to eke out every penny that you possibly can. And when he did that, I said, Jeff, stop. I don't want to negotiate with you. I want to bring you something that you're excited about. So I need you to explain to me everything that you don't like about those traditional payers. I need to know exactly what that is, what that looks like in an agreement, and we're going to eliminate all of it. And what we're going to do is we're going to bring you something where now you really have a relationship with the purchasers in the marketplace. Because if my clients, those purchasers, knew how you felt about Blue Cross, they're the ones funding them and giving them all that leverage against you, they would be pissed, because it's their employees and your patients are ultimately the ones that are suffering here. And then they get to pay 15% more for that luxury of basically screwing you over, right? So it was in those moments where I really started to recognize that, when I had been with the insurance carriers, and I always used to call them the bulldozer, until I realized I was the one that was in the driver's seat, because I had been sitting there telling these clients every year, just here's the spreadsheet, pick the option that sucks the least, right?
Okay.
Spreadsheeting, as we call it. And it was in all of this when I realized, wait a minute, I finally have the opportunity to do something different, because this guy who really represents healthcare in his community, he's got more control than anybody, and he also wants to do something different. So when we put our first contract together, we called it a direct corporate health partnership, because that's how we really viewed it. Was I was just a catalyst for it. I was going to go communicate and deliver it to the marketplace. At the end of the day, it was he and the employers that were really the ones that were participating in this agreement. I was just help facilitating that at that point. And so I think that's one of those great lessons I learned right then, is that we have to look differently at healthcare, not as something that we should hate, but rather look at the things that are good about it and say, how do we exploit that, and then push all of the other stuff aside.
Man, what a great story. I mean, that guy should send you a bill for your MBA, right? In regards to healthcare economics. Doug, maybe let's rewind, and you said kind of some of it, but just to throw a glossary out there. What is a direct contract, and how does that differ from how most employers and advisors that are going to be listening to this purchase their healthcare today?
Yeah. A direct contract at the end of the day is just a piece of paper. I think it's the intent behind it is what's really important, right? So let's face it, in a traditional sense, an employer, they're going to go purchase a network in most instances. And for the most part, it includes all of the doctors, right? There's nothing preferred. That PPO name, throw it out. Those are called APOs. And what I really came to this realization is that most employers have most of their employees within a really pretty small definable geographic region. And often that defined region tends to almost perfectly overlap 1 to 2 health systems, right? So hospitals, all of their doctors. And so at the end of the day, to me, this direct contract represents a direct business relationship between the plan and all of those participants, and then these facilities and all of the doctors that in essence make that go. So it's kind of supplemental to what you might think of as a network, right? I really don't view it. I think it's this idea to say, hey, the network's great for when my employee's traveling, or for maybe that small segment of employees that are spread out across the country. But at the end of the day, I, as an employer, if I really, one, care about my employees and my business financially, and two, want to actually stop looking at the insurance carrier as the risk manager, and rather now treat the providers as the risk manager, this direct contract really becomes the vehicle by which I can do that, which, if you think about it, is how they run their company in every other facets, right? It's healthcare is the only one where it's like we just blindly, okay, that's the health plan and insurance carrier I'm going with this year. And then they have no idea, why they're getting this terrible result. And again, like I say, every year, they're just picking the option that sucks the least with no expectation of it ever getting better. And I think that's what a direct contract is. It's the first opportunity for them to take control, but just as importantly for the provider to take control. Because that's what I've also learned is if you go to any health system and say, who are the major employers? Who have you engaged with out there, about maybe having a direct relationship? They look at you like just deer in headlights. And I'm like, well, why is that? And they say, well, because the insurance carriers won't let us go talk to them. And I'm like, why? Who says that? They've got you convinced that you need them. I get it. But at the end of the day, why can't you drive over to, ABC Plumbing and go have a conversation with that CEO, just like he's never considered the idea he can walk into your corporate headquarters and do the same thing in your office? It's this like evolutionary thought process. And yet again, It's how we do business everywhere else. So to me, it just seemed like common sense and something we should be doing on a more regular basis.
Yeah, love it. Love it. Doug, explain the WIFM, right? The what's in it for me for all of the parties. Because, theoretically, somebody would look at this and let's play with your Blues in Idaho, right? It's like, wait, the Blues are purchasing, let's call it the Sam's Club method, right? More units equal lower unit cost. So theoretically, somebody would look at it and be like, there's no way this little guy in Idaho is negotiating a better deal with that hospital than Blue Cross. Talk about the economics and the WIFM for all of the.
No, I love this part. I think the first part is look at it just from what we're doing today when we buy from insurance carriers. Again, abdicating full responsibility back to them, right? And at the end of the day, we always look at it and go, the employer's not happy, the patient isn't happy. And then what I've really come to find out is the providers are just as unhappy with the current model, right? So everyone's disadvantaged. And yet you say, well, who always wins in this? The insurance carrier. They're always profitable, right? They never go out of business. So the house always wins, I think, in the traditional model. And I think and I always think of it as a shareholder-based model, because at the end of the day, most insurance companies are stood up on shareholders' backs financially, and they're the ones that are winning as well. So in this direct contract arrangement, we're flipping the script, and I think of it more as a stakeholder model. And to me, the key stakeholders here are going to be the employer, the employee/patient, and the provider. So let's start with the employer, right? So I already kind of mentioned some of it, but first off, they really can get a better deal. So, from a unit cost standpoint, if I'm going to provide some level of incentive or communicate to my employee and workforce, say, hey, go here, not there, you're going to increase utilization to that hospital. That's more revenue, more activity. That's good for any business, right? So the provider loves that. So utilization goes up. But now I have an opportunity as an employer to also say, hey, I also want you to do a better job of managing the risk. I'm going to keep them coming to you, right? So that now I want you to develop a relationship. So we always tell the employers it starts with communication, and that we're not going to have this idea of, hey, don't use healthcare because it's too expensive or you're going to impact my renewal, but rather, no, I need you to go. I need you to engage with your doctor, develop that relationship, and ultimately trust that that provider has your best well-being in mind. And ultimately, as a population, we should get healthier. So then that provides a level of stability. The other side of it is for the employer is that in essence, you're now anchoring your financial experience to that of the hospital. Something that I've learned over the years is everybody talks about healthcare inflation, and it's a bad terminology. It's health insurance inflation is what it really is, because when you detach yourself from the traditional insurance system and anchor against that healthcare provider, you begin to experience what all of the financials out there tell you is that healthcare systems and providers on average go up at about 2.4%. Just like ordinary inflation. Well, what happens to your health plan then? 2.4%, just like ordinary inflation. So those are some of the benefits to the employer. Now let's trail over to the provider. Now there's a financial perspective. So let's increase utilization because we're going to get people to go to them more. That is a big deal for most providers, right? You go to any, town that has 3 hospitals and they're each going to be about 33, 35% market share. Well, what if all of a sudden you're picking up 80%, 90% market share from any given employer? That's like having almost like 3 patients to every one. So that is excellent for the bottom line. But just as importantly, what you find out is that insurance carriers, their job is to not pay. Well, the employer doesn't have that attitude. The employer says, hey, you provided a service. We had a deal in place. I pay you, right? They direct the TPA to say, stop off some of this nonsense. We'll do pre-adjudication audits, not post-adjudication. We're going to pay accurate, and we're going to pay probably within 10 to 15 business days at the most. So now you never even land on that hospital's AR report, right? So inherently they're going, this is some of the best commercial revenue that we've ever had. So then that's why they're motivated to give a great deal in return. Now, I mentioned something there that was really important, and that's utilization. How do you get people to select one provider versus another? Plan design. When I first put this together, that was one of the things that I really keyed in on. And it was, guys like Dave Chase, Marty McCary. I met both of them in one day up in Montana. And it was amazing when, I looked at it and I'm like, okay, these guys are different. They're not just looking at the cost side of it, but they're looking at kind of the human factor. And they're taking this holistic approach that says the dollar is what's getting in the way of healthcare. So when I put my first contract in place with that hospital in Eastern Idaho, and I went to him and I said, here's what I want to offer you based on your feedback and also my experience of, 7-8 years of being a broker, is that we need to get the money out of the way. So it's going to be pretty simple for your doctors. It's a $10 copay. And I don't care what happens in that service. It's $10. Everything else is being paid, diagnostics, all of that. Heck, your doc, all of a sudden identifies, I got a patient with a behavioral health issue. Great. Take them right over to the behavioral health provider. Don't even charge them another copay, right? The plan will pay whole. We'll just call it one healthcare event. So he loved that. Then the next part was, as I said, any facility-based procedure, it's $400. And why did we do that? Because usually when you're looking at facilities, it's deductible, then it's co-insurance, up to some unknown out of pocket that I'm not even sure how we're ever going to get there. So I never know what I'm going to pay. But all of a sudden it's, wait a minute, this could be an MRI clear up to, I could go get a spinal fusion, $400. Yeah. Okay. I think I'll go there. One of the things that Bingham was really kind of famous for was maternity, right? And they had a nice maternity ward. They just built it out, and yet they weren't very full. And so I said to him, one of the things that drives me crazy about these health plans is what happens with the members, right? When they're having kids, you got 20-somethings, 30-somethings, they're early in their careers, don't have a lot of money, and 30% of the time they're ending up in financial peril, even bankruptcy, because they expanded their family. So here's what we're going to do. It's $400 for mom for the entire global maternity event, and we're not going to charge the kid for showing up. The kid is free when they're delivered, and ultimately, please just put them on the plan. So now it's like, you probably see me, it's like we've even got these banners that we have, and I put it on LinkedIn fairly often, free babies. What a novel concept, to where now, like, I've seen women, you'll be in a room rolling this out to them, and they're coming off of a $3,000 deductible, $5,000 out of pocket, thinking, okay, I'm going to be somewhere between $6,000 to $10,000 for having a new child. And you're standing in front of the room and saying, hey, go to this hospital instead, and it's $400. I've literally watched women weep. I've watched HR directors see their employees get emotional, that they're weeping. I even had one time we were doing this with the hospital, and the marketing guy happened to be there. One of the women was so excited about it, he then invited her. He drove her over to the hospital and gave her a personal tour of the maternity wing just so she knew exactly what the experience would be like. How awesome, right? So that's how we get then patients to do what we want them to do, ultimately eliminate the financial cost share for them. And now, because they know exactly what they're going to spend when they walk in the door, they continue to walk through the door. And so then what we've seen through some of these populations is year 2, year 3, year 4, we're watching the utilization, and all of a sudden you're going, okay, we had an uptick in overall, professional services. People are back going to the doctor again. We had a bit of an uptick in outpatient, and inpatient stayed fairly flat until you get to about year 2 or 3. Outpatient comes back down to normal, and inpatient starts to flatline, to where all of a sudden you're going, wait a minute. Is this proof that actually just by getting people to go to the doctor, and because we removed the dollar, they're actually getting healthier? And that's some of the indications that we see in a direct contract. So now let's circle all the way back around. What happens to renewals as a result, right? We have a lot of groups that are very accustomed now to getting zeros on their renewals at this point. So what do? Nothing. They just sign the piece of paper at renewal and say, great. Let's keep sending people back to our direct contracted health system. And for the hospital, they're looking at it and going, not only do I now have preferred business, I know who's coming through the door and that they're going to continue to come through the door. So inherently, all of the 3 stakeholders have massive advantages by engaging in a direct relationship.
So, Doug, you mentioned and you mentioned it when you sat down with the CFO, and he's like, hey, this is tough to collect and blah, blah, blah. And you mentioned the model never hits the AR. I've seen stats all over the place in regards to like, how much does it actually cost a hospital to collect? Because that notion there is the economic trigger of
Huge.
what makes all of this make sense is like, if we eliminate this person goes over here and they don't have to collect. And this is what it normally costs somebody to collect. What are you seeing across the country's benchmarks there?
Yeah, a couple of data points. So like the American Hospital Association last year did a study, and consider the source, right? I get it. It's probably a little bit biased, but they're basically saying that just right out of the gates from the administrative burdens that are put on them by the insurance carriers, 39 cents on the dollar are going to administration. So let's just say right out of the gates, right, we're going to have to inflate healthcare pricing by 40%. Just to offset the burden of engaging in insurance. So that's the first part of it. Now, let's say we get back to the net dollar of actually what's being collected. And these are pretty general numbers, but they're pretty close. So a hospital's going to go and negotiate with an insurance carrier for $1, right? So take the 40 cents out. Now we're going to collect our net dollar. Here's the problem with that. They don't actually collect all of that from the payer. We've got deductibles, co-insurance, out-of-pockets. So at the end of the day, and it's a degrading number because, right, they keep pushing those numbers up further and further every year. I think when we started this back, this was probably like 7-8 years ago, we were tracking at about 78 cents on the dollar. I've talked to plenty of CFOs that say, yeah, that's pretty close. 78 cents was being paid by the payer, having to now go collect another 22 cents from the patient. That is getting worse. We're now down to where in some instances you're 73 cents, 70 cents on the dollar, and the rest is being collected on the patient. Now, does the patient pay right away? Does the patient just show up, get their bill, and say, okay, I'll write my check, and here's the 30 cents? Oh, goodness gracious, no. That's where the real ugly within the AR shows up. So now you've got all of these dollars out there that you're having to go collect on. You're having to hire staff for this. You're having to go hire third parties to go do these recoveries. Sometimes the patients are now financing their healthcare. They're paying with credit cards. That's not a full payment. So all of these things are happening to where at the end of the day right now, studies came out last year that on average, hospitals are collecting somewhere between 83 and 85 cents on the dollar of what they've actually negotiated with the carrier. So when I go and have a conversation with a hospital, we go through this conversation and they're just sitting here and nodding. Yep, that's exactly what's happening. And I look at them and I say, great, here's what I'd like to do. Let's cut out all the administrative nonsense first and foremost. We're just going to pay you if you provide a service. I'm going to get people here all the time. Just tell me what that 83 cents is today. I'll go ahead and take the deal. There's no cost share to the patient. It's tier 0 moving forward, right? Zero direct is what I like to call it. And they sit there and they're like, you can do that? And I'm like, absolutely, we can do that. Let's get this nonsense out of the way. You know you're going to collect 83 cents. I know you're going to collect 83 cents. Let's just pay you 83 cents and call it a day. It's very simple.
I love the conversation. I'd be curious to get, I got interviewed the other day and somebody asked me like, in this conversation, like, what's the aha or what was the wow moment? I said, the wow moment is there's a lot of people that are willing to have this conversation. So it's actually a lot easier than I would have thought to start the conversation. Yeah. But on the flip side of the wow moment, when you ask that question, that 83 cents, I was kind of shocked, if I'm being honest, how many people couldn't answer that question of like, what's your net collect? Like, what's that 83 cents? I was kind of shocked how many CFOs of hundreds and hundreds of millions of dollars of revenue flowing that couldn't tell me a simple like number like that. Is that something that you see regularly?
So common. I think part of the problem is we think in the terms of cost, right? And that's like, we go look at a hamburger and we can compare one, fast food joint to the next, and we can get an idea, well, the cost of the double cheeseburger at each of those is going to be roughly X. You add lettuce, onion, tomato, it's going to be another $1.79, whatever that is. Like, so there's some barometer by which we can compare out there. Healthcare just doesn't work that way. This kind of goes back to the idea that first and foremost, they have to be everything to everybody. So they got to do everything. So the number of cheeseburgers that a hospital is serving up is infinite, partially because one patient isn't the same as the next, right? So you have a 30-year-old that comes in for a hip replacement versus an 80-year-old that comes in for a hip replacement. Those numbers are going to be really far off. And what we're really thinking is more in the sense of, well, how much am I actually going to get reimbursed? Not what are my actual costs? Like you, the very first couple of times I sat down with hospital CFOs, and I remember this, I was out in Pennsylvania. It was a hospital system that was probably running right at about $1 billion a year in revenue, right? We're sitting with the whole C-suite. We're throwing this concept out. They're absolutely loving it. The CEO's like, we are doing this, right? And he looks at the CFO and he says, okay, you guys figure this out together and then, come back and tell me what you've decided. And he leaves the room. So everything gets kind of quiet. We're sitting there and and all of a sudden the CFO, he kind of leans into me and gets real close and he goes, what if I don't really know my costs? And he said it with just this sense of embarrassment. And I felt bad in a way, but it wasn't the first time I had heard it. It was just at such scale. I kind of looked at him and I said, that's okay. Neither does anybody else. What we have to start with first is, what does it take to keep your lights on? That's what's most important in all of this is that, I hear a lot of people that get into direct contracting, and especially those that have some understanding of reference-based pricing, right? Some Medicare multiple, and they think, 150% of Medicare, I would never pay more than that. Well, that's all fine and dandy, but understand that 150% of Medicare in South Carolina is not the same as 150% of Medicare in, Washington, for example. So out here where I live in Idaho, I can tell you right now, it probably takes 190% to 200% of Medicare just to keep the lights on, right? And that's the challenge with it that I think most people don't understand. And this is what CFOs are dealing with every day is payer mix. Most people are like, I don't understand. What's payer mix? Well, think of it this way. Just take any health system and assume there's 100 people that go there every year. Know that roughly 70 of them are going to fall into the government or cash pay category, Medicare, Medicaid, uninsured, right? So every single one of those people, when they go in, ultimately aren't covering costs. So they're going to leave that hospital in a deficit. Some hospitals are pretty efficient, running fairly close to what their costs are. But the reality is many of them are running at like 75 cents on the dollar. So imagine that the first 70 people come in, leave the hospital 25 cents underwater each. Now you're left with the commercial market, 30 more patients that not only do they have to cover costs for themselves, plus a margin, they got to make up for all the losses of the first 70 people that walked through the hospital. So that's where it's like this crazy equation. And I didn't used to be this way, but I rail on our federal government pretty hard anymore because I look at it and go, you guys are the reason we're in this mess. You guys created Medicare and Medicaid, and at the end of the day, you are shafting the providers out there, which then means the commercial market, the businesses, and the middle class, the working stiffs, we have to make up for everybody else. Plus, we get these huge deductibles and out-of-pockets where Medicare recipients, Medicaid recipients, their healthcare is almost free, right? So we've really got like two completely different systems of healthcare. And that's why it's so challenging for a financial leader, even a clinical leader within a hospital, to figure out how to find some balance and really run an equitable organization. It's extremely challenging.
Doug, what portion, and this is okay if this is just, Doug Hetherington's, opinion, but I hear that, and then on the other end, I would be like, if I was somebody else, I would say, well, wait a second. I've also seen, some hospitals, their CEO's salary, and I see that there's, 800 people working at this department, and you might say where does the operational efficiency? You and I both run businesses, and so you look at it, it says, I got to charge enough over here to keep the lights on. But in order to know what this number is, and in order for this to make the sense to everybody else, I also got to run a good back room. And so where do you see that, balancing act between getting shafted, in payer mix and that mix and running a more efficient ship?
Yeah, Part of it is the system isn't designed to be efficient. Let's just start there, right?
That's a great point. Yeah.
Yeah, Medicare, Medicaid, maybe they are, they run in their way, but then the commercial market almost runs in a whole different way. So if you're the CEO of this hospital making $1 million a year, in essence, you're trying to run two simultaneous businesses that have two different sets of rules. And then you have all of these regulations that are constantly coming at you and constantly changing. So in essence, the ball's constantly moving, right? And that's what makes it really difficult. But I think just as importantly, going back to the equation of the 39 cents on the dollar that's going towards administration, I don't think a lot of people realize that. They think in the terms of my clinical experience, right? What was it like for me when I went to the hospital, went to the doctor, not realizing that that was only 15% of all of the work that was put in. You just know what happened when you were in the room, right. But what about all the scheduling leading up to that? What about all the collection after that? What about even while you were there, the insurance verification? It takes people to do that. And then you look at healthcare and like, you probably looked at it like I have, Lester. I mean, when I got into this and started doing direct contracting, I didn't even understand claims flow. And now that I understand it, I look at it and I go, I don't know who created this, but they created it for healthcare to fail. Like, this is the most complex, nonsensical system that most people don't realize that any single claim probably gets touched by a minimum of 15 to 20 entities before it actually is kind of finally paid. And I've seen instances where it's probably 60 or 70 touch points of a claim. Well, every single one of those has a cost factor to it. Every single one of those has people behind that. Then people building systems, which none of these systems then talk with one another. So I would argue that, yeah, these hospital systems are incredibly bloated, right? You could have 15,000, 20,000 employees. How many of those are actually clinicians? Probably 10% or less, right? That's probably not far off. So healthcare is an ugly business. And, at the end of the day, this is where I kind of look at that inequality between having, the federal government propping up the federal systems that underpay. It's creating a lot of work on the other side. Now you have insurance companies that are financially motivated. Our job is not to pay. Well, great. Now you got people trying to collect all the time. So most of the people, again, that are involved in healthcare are working just to keep the lights on for that 10, 12% of the clinicians that are actually making a difference in the world. It's an ugly business for sure.
Yeah, I agree. I want to go back to, and then I want to get into like proof is in the pudding. I want to go back to something you said about utilization, right? Hey, we eliminate the out of pocket. That's where most people are not doing the things that make them healthy, yada, yada, yada.
Yeah.
I love that. I know what the answer to this question is, but I often get a CFO being like, timeout. How am I going to save money when you put the red light, green light on green? Am I just going to have a bunch of people go get procedures and is the utilization going to spike up so much that my cost? Talk to me about that.
Yeah, right. We hear this from the reinsurance carriers when you're coming off of a $5,000 deductible and going to zero. They're like, oh, I've got to increase the risk, right? The payout of risk like 40, 50%. You go, why? Isn't it matter more where we go and how we're going there and why we're going there, right? So I think that's very important. So we kind of promote appropriate utilization of healthcare. Now, let me also ask you this. Who actually likes to engage in healthcare?
Just think of that. Like, give me my second colonoscopy this month, please.
Right now. Sign me up, man. In fact, can we come back and do that again next week? Like, I had a really good nap. No, people really don't want to engage in healthcare to the point, right? It's a sterile environment. We kind of feel like, I got to stay out of the way. Now I got to come in and people are going to be poking and prodding at me. No, that's not what people want to do. They want to go on vacation, head down to Puerto Rico and enjoy the sun, right? I mean, that's what we really want to do at the end of the day. So I think what really is important, it's this idea of go here, not there. So, I've heard a lot of people that say, well, I would never go to that hospital. I would have to go to MD Anderson, Mayo Clinic, Cleveland Clinic. Well, it's all fine and dandy. But what you need to realize is when you start looking at the quality ratings, there may be a handful of areas that those guys have really good ratings and probably can make a big difference for certain folks. But for 99.9% of us, all they're doing is convincing us because their marketing budget is way bigger than everybody else in healthcare, right? They're the exception, not the rule. They've figured out that, hey, if we actually sell ourselves and tell people how great we are, they're going to want to come to us, which means we can charge them 4 or 5 times more than what they would get if they went to their local hospital, or even more importantly, go to the local ASC. This gets back to like who we are in commercial health plans. We're the working class. We tend to be younger, healthier, more mobile. Healthcare for us, even in a procedure, right? A knee procedure, hip replacements. We're starting to do these on an outpatient basis. We don't need 3 or 4 days of hospitalization like a geriatric patient would. So why do we even need to go to the hospital where that hip is going to be $50,000 or $60,000? Rather, I can go to the local ASC, pull up right to the front door, walk in, get in the gurney. They're going to move me through one room. Now I'm in the surgery room. I'm one room over for recovery. And that afternoon, I'm walking out of the place for $20,000. So now we're reducing the overhead by 2/3. So that's what we tell people, honestly, is that it's like, listen, yeah, healthcare is expensive, no doubt about it. But if we're a little smarter about it and say, go here, not there, there's no reason that we need to spend more money than we did before. In fact, our experience on a lot of our plans is that when you compare it to like reference-based pricing, our plans tend to run pretty much in line with most RBP plans. Maybe it's 5% more, a little bit more. And instead of paying the RBP vendor all of these crazy fees, let's just pay the doctor a little bit more, make them happy, wash our hands of it, and now have a stable financial experience moving forward.
Well, and when you take the relationship with the provider and you take the member responsibility out of it, right? It's instead of not sending you what you want to make on it, it's we're going to agree on this. So longer term, community based, it's a much bigger, scenario there. Doug,
you touched on something there, right? Community. I'm big on that. Like, I think
100%.
What these are is, the like Health Rosetta and their terms, community health plans, which I think is starting to spread as a concept out there. We're starting to see more and more of that, to where, it used to just be direct contracting. And then we came across an organization about 5 years ago in Missouri where the doctors had come together and said, well, we want to do something. Several hospitals, hundreds of doctors had all signed up in this cooperative. And yet they had no infrastructure. They didn't really know how to put themselves out in the market. And so we said, well, hey, why don't you guys establish a reimbursement schedule, send us all your TINs and MPIs, and we'll make you guys into a network. They now have 14,000 lives that we're managing for them across probably, dozen different TPAs, all kinds of different employers. And who are the number one purchasers of those health plans? The hospitals and the providers, right? Almost all of them have jumped into it at this point. And so they really feel like as a community, right, they have ownership of this at this point. Right. As a community, they've removed themselves from the insurance structure. And it's amazing. And their rule is 3 no's. No deductibles, no copays, no co-insurance. Here's your 100% of Medicare contract. And the plans run fantastic, and everybody just keeps renewing every single year. So it's a win-win-win from our perspective.
Love it. Love it. So let's personify this for folks. Like I think everybody, and I'm hoping, people listening are even hospitals, right? Let's take a scenario like, where was the direct contract, and talk about an employer situation, and maybe talk about it in that triangle. What did the patient see? What did the employers see? And what did the hospital see at the end of the day?
Yeah, I mean, we have examples. We're in 7 or 8, markets, as I call it, states, really, if you will. And we've got probably great experiences in every single one of them. I think about one in particular, and this was really interesting. This wasn't too long after the employer had moved into the direct contract arrangement. They were more of a distributor than anything, right? And out here in Idaho, and I remember I'd been the broker on it, and now I'm like the vendor running their direct contracts. And I remember getting a call from the VP of HR one day, and she called me up and she said, hey, do you recall when we first moved forward with you as a broker, and the last question that the owner asked you as he was walking out the room? And I said, yeah, I actually do. You mean about bariatric procedures? And she said, yes. And I said, okay, yeah, I remember that. And she goes, do you remember what you said? And I said, yeah. I said, the industry tends to frown on it, but I would personally say that based on the success I think you guys are going to have with this, it's probably something you could start to consider doing in the future. And then he just turned and left and walked out. That's what I remember from it. And she said, yeah, well, he just walked in my office and he's ready to move forward. And I was like, oh, wow, this is pretty cool. And the hospital we were working with happened to be a Centers of Excellence for Bariatrics, and we had a fantastic price. So I'm kind of excited about this. Well, it was a few weeks later when I'm talking to the VP of HR again, right? And she's kind of giving me this story of the why. And this is when it kind of hit me of like, oh, wow, we're really making a difference here. Come to find out, the reason that he had done this and why he had even asked that question to me originally was that he had an employee that had been with them for almost 20 years. The guy was literally like 38 years old, had 3 kids. He and his wife both were quite obese. But as I found out, the day when he started at that company, when he was 18 years old, he was like, 6'2", 180 pounds. And so the owner had seen this take place. And then, the guy gets married, has children, and the owner's like literally looking at this, and he can kind of see what's the legacy within this family where, okay, both parents are struggling with obesity, probably going to happen with the kids. And all of a sudden it was this guy that comes into the owner and says, I have to quit my job. And the owner was like, what do you mean you have to quit? And he said, well, I just met with the doctor. Here's my health issues. Here's my multiple morbidities. And ultimately he says, if I don't, I probably only have like 6 months to live. And so, they're going to try to do some of these different things with me. And that's when the owner went to the HR director and said, done, we're doing it, move forward, right? This is worth it. So then come to find out, it's about a year and a half later, I'm doing an open enrollment meeting and, we're going along and all of this stuff. And I see this guy walk in the room and I happen to know who the employee was, right? Back down to him now, probably was almost 400 pounds when he went in for the procedure, now down to about 220 pounds, right? And I'm blown away. At the end of the open enrollment meeting, this employee comes up to me and says, hey, I want to thank you so much for everything you've done for our health plan and what you've done for my family. And I'm like, what do you mean by that? And he said, well, I've talked to the owner, and he kind of explained to me the process about how it came to be that we now cover these types of procedures. And not only did you completely change my life, my wife just had her procedure 3 months ago. And like, I'm just sitting here and I'm like, oh my goodness. All the while, I didn't realize that VP of HR is standing off to the side and she sees this interaction going on, right? And she comes up to me and she just has this grin on her face. She is beaming as an employer. And she looks at it and she goes, so what was that all about? And I just said, he was thanking me. And she said, yeah, we're all thanking you. You've changed our company culture. Like, to me, that was so powerful of something that just by doing something a little different, working with the healthcare provider, having a vision that we could do something better, that literally now it's changing people's lives. And now what's the impact to that guy's kids, right? So to me, those are wonderful stories. Now, I didn't get to necessarily hear from the provider on that one, right? Patient confidentiality. But I do know that when I've talked to some of my providers where they do bariatric procedures, Bingham, the first hospital being one of those as well, we've had dozens of members go through and get their procedures. Now we're starting to see these same employers that are investing in the GLP-1s and the well-being of their employees. They wouldn't have been able to do that if they just stayed in that traditional insurance model. From the provider's perspective, I think one of the best things was really this last year. I spent a fair amount of time because we don't always hear from our providers a lot. We have great contracts with them, great relationships when we get it established, and then we just kind of go back to business as usual. And it was really interesting that I kept, reading all of these, markets across the country where, hospitals going into renegotiations with name your insurance carrier. They're about to go out and network. And now the vicious letters and the media is coming out. And right, this wasn't happening when I first got in the industry. Now it's prevalent. And it never did happen to us. And I just kept waiting for an email, kept waiting for a phone call, and they didn't come. So I finally went back to most of my hospitals last year and I just said, I want to have an honest, transparent conversation and ask why. Like, you guys haven't. And maybe we're just not that big that we don't matter that much, but it does matter to me. Like, if we're not paying you right, or, our employers are going to put you underwater, hey, let's have this conversation, do whatever reset is necessary. And to a T, not a single one of them did that. In fact, last year, we had several of them that when this conversation came up said, we're going to hold the line for you guys this year. Why? Like, what is it we're doing different? And I remember it was one of the senior VPs of revenue cycle and payer relations. So he definitely seeing what's going on financially within the health system. And he said, Doug, if I compare health to business to all of our commercial contracts out there, you guys are number one and by a mile. And I was like, okay, unpack that for me. Why? Like, what do you really mean by that? And he paused for a moment and he said, I think it's this. It's that we certainly need payers and we need them to do the things that they're supposed to do. And that's what makes you guys unique, is that you do everything we need you to and nothing else. You let us be providers. We collect timely, accurately, and we never have issues. And I never see a report that has your guys' name on it. So when we really think about what do we think the future of healthcare looks like, we hope it looks a lot more like what you guys are doing in the market with your employers, because we really do think of you as partners. And to me, it was like, okay, that's fulfilling. Like, now we're really doing something where we know we're beginning to make a difference in the marketplace.
Man, that is, if there's a better way to end, I don't know what it is. And I told you when we were prepping for this, the why versus the I in Dysrupt. And you just said it right there. Like, what gets us up in the morning to do this? It's doing the right things, because in this business, it's such a big business that you could still do well. You could build a business, but you could still put the patient in the middle of it and know that you're doing the right thing. And it's so awesome. Doug, if you had to leave the audience with one thing, what's the one thing you would leave everybody with?
Have hope, pay attention, have hope. Don't be apathetic. I think that's where, whether it's brokers that are out there, if it's employers, right? I think we all just push it off and think, well, somebody else is going to come solve this problem. And the reality is they're not, right? The cavalry is not coming here, right? It's getting worse and worse and worse every year. So I always tell people that, the first step to solving your problem is taking the first step, right? It's engaging in some level of education. We tell people all the time, we may not be the right solution for you, but you at least need to understand self-funding to begin with, because that's kind of the first step of getting here, to even determine, all right, does this make sense for me? And you may go down this journey, and then the funnest part is when people do. They engage in this education, they get excited, they keep learning, and then they keep asking the same questions over and over and over. And that's when I look at them and say, it's now time to make a decision, right? Are you going to continue to just pick the option that sucks the least, or are you now going to take ownership of your future? So don't sit back on your laurels, engage, get educated, and make a decision around what's right for you, whether a broker, employer, whatever that may be.
The definition of insanity, right? So Doug, thank you so much for being on. This was, I think I could have 7 more hours of conversation with you. Thank you for being a leader in the space and pushing for change, because I agree with you that the cavalry is not coming all the time, and having people like you in the industry is absolutely needed. So thanks so much.
Well, feeling is mutual, Lester. You as well. Been watching you for quite a few years, and I'm glad we're on the same side together for sure.
Awesome. To our audience, man, this is something that everybody needs to hear. We don't get paid for ads. I don't have any sponsors. This is 100% what Doug just said. Get educated. And Doug just provided an MBA level course on doing something different. So Doug, thanks so much. Audience members, hit like, share, give it to one other person that you think might like this conversation. And as always, just help us continue to disrupt healthcare. Thanks so much, and we'll see you next time.